Hi, today we are going to discuss about retinoblastoma. This is very important for your MCQ in your NEET, FMG, MRCS exams. So first coming on to retinoblastoma. Retinoblastoma is the most common congenital malignant tumor in childhood. So when you talk about the most common malignant tumor of childhood, so it is going to be retinoblastoma. So it is also important in your pediatrics. So what is this retinoblastoma? It is this malignant tumor which is affecting the neurosensory part of your retina. So this affects your neurosensory retina. Now this can be unilateral or it can be bilateral. Usually children with retinoblastoma, they can be diagnosed in 3 to 4 years of their life. So 90% of the diagnosis is made less than 4 years and 98% is diagnosed less than 5 years of age. Now with this introduction, we'll see what is the genetic problem in retinoblastoma. So genetics involving this retinoblastoma is mainly with the retinoblastoma gene. So it is with the retinoblastoma gene. Now this retinoblastoma gene is identified as your 14 band on long arm of chromosome 13, which can be written as 13q14. So it is on the long arm of 13th chromosome on the 14th band. So whenever there is a 2-hit mutation on this retinoblastoma gene, then this can result in retinoblastoma. Now why when there is mutation it can result in a malignancy? Because this retinoblastoma gene normally is a tumor suppressor gene. So this inhibits the development of tumor. So therefore this basically is a tumor suppressor gene. So when there are 2 mutations which is affecting the gene, then this is going to cause retinoblastoma. So this is given by the hypothesis Knudsen's 2-hit hypothesis. So which states that when there are 2 mutations, it can result in retinoblastoma. Retinoblastoma can occur as hereditary form or non-hereditary form. So hereditary form, 40% of retinoblastoma or hereditary form, where it usually affects both the eyes, so it is bilateral. Now apart from retinoblastoma, they can also have other malignancies, so therefore it affects the other organs also, so it is multifocal. Now when retinoblastoma is present bilateral and it is also associated with pinealoblastoma, it is called as trilateral retinoblastoma. This is an important MCQ. So this can be asked as an MCQ. So which of the following tumors is involved in trilateral retinoblastoma? So it is mainly your pineal gland which is involved. So it is called as the pinealoblastoma. So when this is also there, then it is called as trilateral retinoblastoma. And this is usually inherited as autosomal dominant type of inheritance. When we talk about non-hereditary form, 60% of the retinoblastoma cases are non-hereditary, where it usually affects one eye, so it is unilateral, and it usually affects only your eye, so therefore it is unifocal. So usually it is unifocal. In retinoblastoma, you can see proliferation of retinoblast. So in the gross features, you can see a white mass within retina. So you can see it as a white mass within the retina. This can be partly solid and partly necrotic. So when this tumor is going to enter into your vitreous, it is going to grow into vitreous, it is called as endophytic. So this is called as endophytic. So when it is going to grow in such a way that it separates the retina and the choroid, then this is going to be called as exophytic. So when the tumor grows outwards to separate the retina and the choroid, it is called exophytic. When tumor grows inwards into the vitreous, it is called as endophytic. Microscopically, you can see undifferentiated retinal cells. You can see undifferentiated retinal cells. Apart from this, you have 2 important characteristic features. So one is called as your Flexner-Winter-Steiner rosettes, and second one is called as the Homer-Wright rosettes. So what you are seeing over here is called as Flexner Winter Steiner rosettes. So here you can see that you have a lumen in the center around which you have got the cells which are arranged with the nuclei away from the lumen. So this is your Flexner Winter Steiner rosettes. Now second one, what you are seeing over here. So this is called as the Homer Wright rosettes. So this is called as Homer Wright rosettes. Now again these two are important for your MCQ. So they might ask you Flexner Winter Steiner rosettes is seen in which of the following? Homer Wright rosettes is seen in which of the following? So it is an important MCQ. So when you see over here, what you can see in the center is called as this neurofibrillary tangles. So around this you have the cells arranged radially. So the radial arrangement of the tumor cells around this neurofibrillary tangles is called as the Homer Wright rosettes. Now these are the important findings. Now apart from this, you can also see necrosis in some areas. And another important finding is calcification. So this is again very important. So you can also see calcification. And finally, you can also see features of dissemination. The dissemination can be into vitreous, or it can be into optic nerve, or it can be into brain, and so on. So these are your pathological findings. The clinical picture of retinoblastoma can be explained under 4 stages. Stage 1 is the quiescent stage. The second stage is your glaucomatous stage. Third one is extraocular extension. And the final stage is your distant metastasis. So first we will move on to the quiescent stage. So what happens in stage 1? So in stage 1, usually you will have leukocoria. So leukocoria is nothing but it is a white pupillary reflex. So what you can see over here on the right side, so you can see the white pupillary reflex. So this is also called as the amerotic. This is also called as the amerotic cat's eye appearance. It is also called as amerotic cat's eye appearance. Some children can also develop squint, especially the convergent squint. Very rarely they can also develop nystagmus. Apart from that, they can also have defective vision. They can also have defective vision. Now when we talk about the ophthalmoscopic findings, now ophthalmoscopic findings will tell you whether the tumor is going to be endophytic or whether the tumor is exophytic. So whether the tumor is endophytic or exophytic. We have already seen that endophytic is it grows into vitreous, exophytic is it grows in such a way that it separates the retina from the choroid. So this endophytic retinoblastoma usually gives a cottage cheese appearance. So this can be seen especially if it is calcified. So you have to remember in endophytic you have cottage cheese appearance because of calcification. So C. So you have cottage cheese appearance because of calcification of the tumor. Now coming on to the exophytic retinoblastoma, so because it is separating the retina from choroid, this gives the appearance of exudative retinal detachment. This gives the appearance of exudative retinal detachment. Now moving on to glaucomatous stage. So when we talk about glaucomatous stage, in stage 2, the child is going to have pain, redness and watering. So the child is going to have pain, redness and watering. They can also have proptosis. And intraocular pressure will be high. And the conjunctiva also looks congested. So they can have congested conjunctiva. Now why there is development of glaucoma and retinoblastoma? So it can be either because of the tumor cells which is clogging the trabecular meshwork. So either because of clogging of trabecular meshwork due to the tumor cells, or it can be because of the tumor which is pushing the lens iris diaphragm forward. So it is either because of pushing the lens iris diaphragm forward. So all this can result in glaucoma. The third one is extraocular extension, where there is enlargement of the tumor and it goes near the limbus or the optic disc, and followed by the extraocular tissue involvement. So all this will result in proptosis. And the last one is distant metastasis. So this distant metastasis can be through lymphatic spread, can be through direct extension, or it can be through hematogenous. So lymphatic spread usually goes to pre-auricular lymph nodes. Now coming on to direct spread, it usually involves the optic nerve, and hematogenous spread, it can go to brain, it can go to liver, etc. Coming on to the diagnosis is basically done under anesthesia. So this is very important, and you have to look for the fundus, you have to check for the intraocular pressure, you have to check for the corneal diameter. This is also important. You have to check for corneal diameter. And you can go for X-ray. X-ray orbit will show you the calcification if it is present. And you can also see the increase in the LDH levels in your aqueous humor. So in your aqueous humor, you can see the increase in the LDH levels. And imaging modalities like your ultrasonography, CT and MRI is very important to diagnose retinoblastoma. So these are very important. Of this ultrasound, you have the A scan and the B scan. So when we talk about B scan, you can see cauliflower-like mass. So in B scan, you can see cauliflower-like mass. With A scan, you can see a typical VY pattern. You can typically see a VY pattern. How do we treat retinoblastoma? So basically, when tumor is diagnosed at early stage, say in stage 1, or when the tumor is involving only less than half of retina, optic nerve is not involved, then you can go for tumor destructive therapy. In this tumor destructive therapy, the present recommendation is to go for SALT. So what is SALT? It is sequential aggressive local therapy. It is called sequential aggressive local therapy. So how do we go about? So first you talk about the size. So when the tumors are going to be large, when it is going to be more than 12 mm in diameter, you're going to treat mainly by chemo. So there is the chemo reduction, which is followed by cryotherapy. So this is when the tumor size is going to be more than 12 mm. Now let us suppose the tumor size is going to be less than 12 mm. So for these people, you can club chemotherapy and radiotherapy. So for them, chemo and radiotherapy is going to be beneficial. Now moving on to the next, when the tumor size is going to be very small, it is less than 4.5 mm. So in this case, you need to know whether the tumor is anterior to equator or posterior to equator. So you need to know whether it is anterior to equator or whether it is posterior to equator. When it is anterior to equator, then you have to go for cryotherapy. When it is posterior to equator, you should know how much it is posterior. So in posterior, how much from macula or from fovea. When it is less than 3 mm from fovea, then you can go on for laser photocoagulation. Laser photocoagulation. When it is going to be posterior but it is away from macula, then you have to go for thermotherapy. Now next one is enucleation. So when more than half of retina is involved, or whenever your optic nerve is also involved, then in such cases you have to go for enucleation. So where you need to take out your eyeball and also maximum length of optic nerve. Followed by this, you also have to give radio and chemotherapy. So you should also give radio and chemotherapy. Whenever the person has got the later stages of retinoblastoma, so with distant metastasis, then only you can suggest chemo and radiotherapy for these people. So chemo and radiotherapy. Now coming on to the last part. So how can you tell the survival of eye with retinoblastoma? So this is given by something called as Rees-Ellsworth classification. So what does this classification say is that this will tell you whether the prognosis is going to be favorable or whether it is going to be unfavorable. So when can you say that the prognosis is going to be favorable? So when the disc diameter is going to be less than 4, and if it is going to be posterior to equator, then it is going to be favorable. You say it is unfavorable when the size is going to be more than 10 disc diameter and it is anterior to equator and it is going to involve more than half of retina. Then the survival of vision in that eye is going to be not possible. So this is measured as disc diameter. So this is the important classification. So again, this can be asked as an MCQ. So retinoblastoma on the whole is very important for your MCQs in your competitive exams. So that completes discussion on retinoblastoma. Thank you.